I'm Anna, and this is the final recording for our comprehensive head-to-toe exam. Before entering the room, I have already washed my hands and performed hand hygiene. I will now introduce myself to my patient and tell them what we'll be doing today. Hi, I'm Anna. What is your name?
Rachel.
Awesome. Nice to meet you, Rachel. Today we will be doing a full head-to-toe exam for you, okay?
Great.
All right, so full head-to-toe meaning every body system. So to start with, we always start with the general appearance of our patient. We are noticing that they do not appear to be any visible distress, any pain. They appear to be overall well and not disheveled in any way. Moving forward, we will start with the head and face. And so we are assessing if you want to scoot to the edge of the bench here, perfect. So we're assessing the head, the hair, the skin. We can also assess the scalp. We are noticing or looking for any hair loss, any patchiness, any breakage in the hair shaft or anything like that. For skin, we're also assessing skin color, making sure it is intact and normal with the patient's ethnicity. Moving on to the face, we can assess for facial symmetry for the patient. When we're assessing the face, we can also assess cranial nerves 5 and 7. And so for cranial nerve 7, that's more facial movement, making sure all the movements are symmetrical. And so for that, Rachel, what I'm going to have you do, it's going to make you look kind of silly, but I'm going to have you puff your cheeks up for me. Good. And then close your eyes really tight, and then raise your eyebrows. Perfect. We can, so basically her movements were intact, symmetrical, no weakness on one side or the other. For cranial nerve 5, that is going to be the trigeminal nerve. And so for that, what we have the patient do is, if you could just clench your jaw, Rachel, good. And then what I want you to do is push your jaw, sorry my hands are cold, against my hand without moving your head. Good, perfect. So we notice that cranial nerve 5 is intact for the muscular sense of the nerve. We can also assess the sensory part of the nerve with light touch. And so for that, Rachel, what I'm going to have you do is just close your eyes, and I want you to tell me when you feel this on your face, okay? So close your eyes.
No. 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 No.
Good. So cranial nerve 5 is intact both with her muscular sense and the sensory sense. After assessing and inspecting, we can move forward with palpation. And so with that, kind of a little bit just deeper than what we did earlier, we palpate the scalp. We are palpating to see if we notice any lumps or masses or any pain when I do that. We can also palpate the facial bones and noticing just if there's any tenderness or swelling there as well. We can also palpate the periorbital area. We can also palpate the lacrimal duct. Again, noticing any pain, drainage. And we can also palpate the sinuses while we are here, or percuss rather, and just making sure we don't notice any pain that might indicate a sinus infection or something along those lines. After we assess, palpate the head and face, we can move on to the eyes. So we'll now move, Rachel, just from, we're going to go head, then we'll do eyes, ears, nose, and then your throat. So for the eyes, we've already palpated around the periorbital area. I could also just pull down your eyelids just a little bit here. Look up for me. Good. We're just noticing the conjunctiva, making sure it's not excessively red, making sure it's kind of light pink color. We can notice the eyelashes, eyelids, and eyebrows, noticing they are all intact. Can also look at the sclera, making sure it's white. A couple other exams we can do with the eyes are testing the pupillary reflex, the extraocular movements, and we can do a visual field test with confrontation. And so we'll start with the visual field test, Rachel. What I'm going to have you do is just look at me, and I'm going to start my hand behind your back where you can't see my fingers, and then I want you to tell me when you can see them, okay?
Now.
Good.
Now.
Good.
Now.
Good. And we'll do the same with this side.
Now. Now. Now.
Good. And we can also do a test, it's called the cover-uncover test. For that, it's testing for any strabismus, nystagmus, any abnormalities you might be able to see. So what, Rachel, I'm going to have you do is just look straight at me, look at my nose, cover one eye, whichever one, and then uncover it. So I'm assessing that one eye that she uncovered for any abnormalities. I do not notice any. And go ahead and do the other one, and then uncover. Good. We can now do the extraocular movements. This is testing for cranial nerves 3, 4, and 6. When we do accommodation of watching the pupils accommodate, we can also, that is also part of cranial nerve 2. And so, Rachel, what I want you to do is just look at my finger and then follow my finger with your eyes, but not your head or anything else. So we're just watching her eye movements, making sure she can move towards all of these locations, and then for accommodation, we will come in close and watch the pupils converge. So everything has appeared to be normal within those exams. We can now move on to test the pupillary reflex, making sure pupils are equal round and reactive to light. And we'll do that with the ophthalmoscope light. I'm just going to cover one eye for me, and just look straight at me. And we're just going to watch the pupil constrict and do the same with the other. Good. And while we have the ophthalmoscope, we can do the ophthalmoscope exam. So I'm going to use, look through this with my right eye into Rachel's right eye. So just look straight ahead for me. Good. And I am visualizing the red eye test, the optic disc, the veins and arteries, then the retinal background, and the macula as well. And then we'll do the same with the left eye. So again, look straight ahead, good job. Good. So do not notice any abnormalities, any opacities. In children, you can sometimes see the first sign of a retinoblastoma with this exam, but everything appeared to be normal for Rachel in this exam. Now moving on, we will move to the ear part of the exam. For that, I'm going to start by just assessing the external part of the ear. We can look behind the ear, make sure there's no redness, or if the patient had any complaints of pain or anything along those lines, we would ask more questions about that. We'll do the exam with the otoscope on both sides. All right, so I'm just going to pull your ear back. All right, good. So we're visualizing the tympanic membrane, the light reflex. We do not notice any effusions or drainage. The auditory canal isn't, it's pink, but it's not overly red. And the same with this other ear as well. In a later part of the exam, I will perform a whisper test to test cranial nerve 8, and just the acoustic nerve, making sure the patient's hearing is intact. We're not going to do that at this moment. After assessing with the otoscope in the ear, we can take this light and look at the patient's nose. So I'm going to just have you tilt your head back for me. Good. And so we're just assessing the septum, the turbinates, making sure they're not swollen, making sure that there's no deviated septum or any visible blockages or any visible drainage there. We can then move from the nose to the throat. So for that, Rachel, I'm just going to have you open your mouth and say ah for me.
Ah.
Good. Stick your tongue out. Say ah again.
Ah.
So we're watching, good. We're watching just the uvula. We see that it is midline, watching the soft palate go up and down when the patient says ah. And noticing just the pink mucosa, and do not notice any abrasions or anything like that. We can also emit a gag reflex for the patient. Sorry, Rachel, just make sure your cranial nerves are intact here. So open your mouth, say ah, and gag. All right. This gag reflex is intact. Also, Rich, if you could just stick your tongue out for me and move it side to side and up and down. Good. So just based on that exam, we can say that cranial nerves 9, 10, and 12 are intact with the gag reflex, with the soft palate moving up and down, and then with the tongue movement and how she articulated her speech earlier in the exam, we can say that all of those nerves are intact. Moving on, we will palpate, see if we can palpate any swollen or painful lymph nodes. So for that, Rach, I'm going to reach behind your head. We're going to do palpate for any occipital nodes, any post-auricular, pre-auricular, tonsillar or submandibular, submental, superficial cervical, anterior and posterior, deep cervical, anterior and posterior, and then supraclavicular. Go ahead and shrug your shoulders for me. Good, and then relax. So supraclavicular, and then infraclavicular. And then for the axilla, which is easier if the patient is lying down, but we can palpate for any swollen lymph nodes under there. So we do not notice any swollen or painful lymph nodes upon palpation. And so moving on, we can also, as we were doing that, you could have been assessing the neck, noticing if there was any enlargement or visible thyroid, also making sure everything appears to be symmetrical there. While we are still sitting forward, we can have the patient do some range of motion exercises with her neck. And so for that, Rachel, what I want you to do is do your chin to chest for flexion, and then look up at the ceiling for extension, and then lateral movement, just ear to each shoulder, and then rotation. Good. We can do some other cranial nerves, so the spinal accessory nerves we can test here with the shoulder shrug. You can do that with resistance as well, and then with the head turn against resistance, making sure that that cranial nerve 11 is intact. And so Rachel's does appear to be intact. So that concludes most of the head, eyes, ears, nose, and throat. Now, Rachel, what I'm going to have you do is kind of face the wall for me a little bit. Good, perfect. And I'm just going to pull your hair out of the way. And so what we can do from back here, I can be behind the patient and palpate, sorry, Rachel's going to be a little uncomfortable, the trachea and moving down into the sternal notch. And then what I can do is palpate the thyroid as she swallows. So I'm going to go ahead and try and find that here, and then go ahead and swallow for me. Okay, good. And so I should feel that thyroid like just roll right under my finger. It shouldn't be extremely enlarged or feel extremely lumpy or vascular. Just should feel smooth under your fingers. While we are back here, we can also assess the posterior chest wall. Ideally, your patient would be in a patient gown where you could visualize the skin here. But we notice that everything appears to be symmetrical and intact. We can also palpate down my patient's spine. And so here we are noticing if there is any pain or discomfort when I do that. It does not appear to be the case for this patient. We can then move on to percussing the lung fields. And so when doing that, we just want to make sure that we're hearing mostly resonance throughout the lung fields as I percuss. Good, which I do. We could also assess thoracic expansion, making sure that the chest expands symmetrically when the patient takes a deep breath in and out. So go ahead and do that for me, Rachel. Deep breath in and out. Good. We can also assess for tactile fremitus, just making sure that noise can come through the lung field. So Rachel, as I move my hands down your background, why don't you just say 99 for me? Go ahead.
99, 99, 99, 99.
Good. And so you should be able to feel the vibration as she says the word 99. Should not be decreased on one side or the other. It should be the same bilaterally. After doing those things, we could also assess for diaphragmatic expansion. This is making sure the diaphragm is not paralyzed or going up or down on one side or the other. So for that, what I'm going to do is percuss again, but this time I'm going to have Rachel take a deep breath in and hold it for me. Good, and so I'm going to percuss until I hear that dullness, until I hear it go from resonance to dullness. I'm going to come over and do it a little bit further. Okay, and then go ahead and breathe. Good. I'll have you breathe on for just a second here. So I have my one area marked here, and then what I'm going to have you do is take a deep breath in and then blow it all out. And again, I would notice where that sound went from resonance to dullness, measuring that fluctuation of the diaphragm, and we would do that bilaterally. For the sake of time and for this exam, we will not. So after measuring diaphragmatic excursion and thoracic expansion, we can now auscultate the posterior lung fields. For that, Rachel, just have you go ahead and take some deep breaths for me. Good. So we notice that lung sounds are clear bilaterally. Do not notice any adventitious sounds. While we are back here, we can also test for CVA tenderness, which could be an indicator of possible kidney inflammation. So now, Rachel, what I have you do is come back, face the camera again. So now we can assess the anterior lung fields. If you could scoot up to the edge for me. So again, we would start with assessing the anterior chest wall, noticing any abnormalities, and noticing skin color, and making sure the skin's intact and all of those things. We will then move on to percussing the anterior lung fields. So again, we should hear the resonance in all of the air-filled or lung spaces. We can then auscultate the anterior lung fields. You can also do tactile fremitus on the anterior lung field, so we will not do that for this exam. Always want to do it in a ladder formation, making sure you're comparing one side to the other. Good. So that concludes the lung portion of this exam. Moving on to the cardiovascular portion of the exam, we're going to have my patient lay her head down to this end over here for me. Okay. So for this part of the exam, we are again assessing the anterior chest wall for any lifts, heaves, and thrills. We can also palpate for those, kind of in the areas where we would listen with a stethoscope. Also, just for assessment purposes, you could assess my patient's jugular vein distension to see if they had any. So for that, if you could just turn your head to the side there, Rachel, and sometimes you should be able to see a slight impulse there, but it does not, should not appear to be bounding or excessively distended. So this patient does not appear to have any jugular vein distension. It appears to be normal for her age and clinical appearance. Moving on, we could now listen to the patient's heart sounds. We're going to listen with the diaphragm and the bell of the stethoscope. So I'm going to do that quickly here. So we have the aortic area, and listen with the bell, pulmonic, listen to Erb's point, the tricuspid area, and the mitral area. Which is typically the point of maximum impulse. For this exam, it's going to be a little bit off camera, but what I'd have you do, Rachel, is just tilt your body slightly to the left, just slightly, where they can kind of still see. And I'm would palpate that point of maximum impulse. And then we could listen as well. And again, it's just a better way to listen for any possible murmurs there. Thank you. So again, if you could not see, that was the fifth intercostal space mid-clavicular line on the left side for the patient. After auscultating, you're listening for normal heart sounds, making sure there's no murmurs that are heard. For the cardiovascular system, you also want to make sure all pulses are intact, and so we will start from go head to toe. So we will start with the temporal, and then we will do the carotid. We do one at a time. We do the brachial, and the radial. We can do the femoral, and then we can do the posterior tibial and the dorsalis pedis. Good. So we notice that all pulses are intact. While you're doing that for cardiovascular system, you're always assessing for any edema you might note as well. So none of that is noted. Cardiovascular system appears to be intact thus far. Moving on from the cardiovascular system to the abdomen and GI. For this, Rachel, I'm going to pull back your shirt just slightly. And so always again start with inspection and assessment. You're making sure there's no visible scars, bruising, wounds, any visible like swelling or lumps. We could also check for a visible hernia by having the patient lift their head up. Just lift your head up for me. Good. And so no lumps or hernias were visible. We will then move on to auscultate the abdomen for bowel sounds. And we do that in all 4 quadrants. And we notice that they are present in all 4 quadrants. You'd always be assessing, make sure they're not hypoactive. While we are auscultating, we can also auscultate the abdominal arteries for any possible bruits. And so we do that with the aorta, and then renal, iliac, and then femoral. And so no bruits were auscultated. We would then move on to percuss the abdomen. And so I'm just going to percuss generally throughout the abdomen first to make sure normal sounds of tympany and dullness were heard throughout. Another thing you can do with percussion is you can percuss over into the left upper quadrant, making sure there's no extended dullness, which could be a sign of an enlarged spleen. You can also percuss the size of a liver, which normal varies per person, but typically 6 to 12 centimeters on that mid-clavicular line, and then 4 to 8 centimeters on that mid-sternal. So for that, I'm going to pull this back a little bit more, and then we would just start as low as you can. And so when you go from that kind of tympany sound to dullness is when you start, and then all the way to when you stop, which again should be about 6 to 12 centimeters. And then the same for the mid-sternal line. Moving on, we could palpate the abdomen. So one thing you can do is palpate the aorta. We already palpated the femoral pulses, but you can also palpate for any possible swollen inguinal nodes from lymph nodes there. We notice that all of those are negative. You can palpate the aorta, that is normal in a young, thin, healthy person. We would then start by light palpation in all 4 quadrants. And you're always assessing the patient's facial signs and seeing if they are having any guarding. And then you move on to deep in all 4 quadrants. You could test for possible appendix inflammation with a variety of signs, one being the McBurney sign, which is just a deep palpation in that right lower quadrant. You could test for any rebound tenderness, which you're assessing for as you palpate throughout. You could assess for Rovsing sign with a deep palpation in the left lower quadrant. And if they had any radiating pain or rebound pain in that right lower quadrant, that could be a sign of appendicitis. We could also attempt to palpate the abdominal organs. They are typically not palpated in a healthy person, but we'll try and palpate the liver, spleen, and kidneys. So for that, Rachel, if I can just have you take a deep breath in for me. And sometimes you can go ahead and breathe out. If the liver was enlarged, sometimes it would kind of drop down as she did that. We can then palpate, or try and palpate the kidney. I'll put my hand behind her back, and then deep breath in for me. Good. And then the same with the other side. Good. And then I'll move my hand up ever so slightly for the spleen. Go ahead and deep breath in. Good. And so no abdominal organs were palpated. Again, that is a normal finding in a healthy individual. While we are lying down, we will move on to the lower extremities portion of the exam. We can pull your shirt back down for me. For the lower extremities, we've already palpated and we've assessed as we're palpating, assessing skin color. We would have assessed mobility as walking into the room. We can also palpate the popliteal pulses, and we already did the posterior tibialis and the dorsalis pedis. For range of motion exercises for the lower extremities, we're going to assess hip, knees, and ankles. Also, when you're doing pulses, you'd assess for redness, pain, any signs of possible DVT. But for range of motion, for hips, we are just going to do a few laying down. We'll do some more when we stand up. So we will do flexion of the hip, which Rachel's just going to be lifting your leg off the table. Good. Good. And then against resistance for me. Good. Good. You can also do internal and external rotation. So if you bring your leg up and then turn it in, kind of put your knee in an L shape, yep, and then turn it in, and then turn it out for internal and external rotation, and the same with the other side. Perfect. Could do flexion and extension for the knee as well while you're lying here, although it's a little bit difficult. So go ahead and put your knee in that 90-degree angle again, and then flexion down, and then extension up. Good. And the same with the other. Flexion down, extension up. Good. For the ankles, we're going to do some dorsiflexion and plantar flexion. So go ahead and bring your feet back, and then push them forward, and then do it against resistance for me. Back, and then forward. Excellent. So no weakness is noted bilaterally in the lower extremities. Moving on from the, we'll also test some sensation and things after we have the patient sit up. So actually, Rachel, I'm going to go ahead and have you sit up and sit on the edge of the bench here. Perfect. So we're going to move back up to the upper extremities. And so always start again with assessing, inspecting, looking at the shoulders, making sure there's no redness, pain, tenderness, or swelling, looking at the hands, wrists, and fingers. We already palpated the pulses. We can do some range of motion exercises with the shoulders, elbows, and wrists. And so for shoulders, what Rachel wants you to do is do some abduction. Just hold your arms up to the side. Good. And then adduction is just one arm in front of you and the other arm coming back in front of you. And then for your elbows, I'm going to have you just do some flexion and extension. And I'm just going to check one thing really quickly. Then for, I did elbows flexion and extension. Now I want you, also for your elbows, you can do some supination and pronation. Good. And then just flexion and extension of your wrists as well. Good. So we do not notice any weakness or pain when doing those exercises, which is great. For the upper and lower extremities, we also want to assess the patient sensation. So for light, dull, and sharp. And so we will start with the light sensation. All right. So for light, I'm just gonna, you're gonna, again, kind of like we did with your face, I'm gonna touch, and then you're gonna say when you feel it, okay? So we'll start up here.
No.
Your shoulder.
No.
And then we're gonna do lower extremities as well, so keep your eyes closed.
No.
I wanna make sure
No.
that you're doing internal and external sides of the extremity.
No.
Good. So now we'll do the difference between dull and sharp. So Rachel, this is going to be dull, and this is going to be sharp. Can you tell the difference? Good. So yeah, keep your eyes closed. We'll do the same thing. Tell me which one's which.
Sharp.
that the patient's sensation is mostly intact. All right. Now we can test for it's kind of positional sensation. And so, Rachel, I want you to keep your eyes closed and then hold your fingers out in front of you. And then tell me which way I'm moving your finger.
Up, down, down, up.
Good. And do the same with your toes. Kind of put your heels up. There you go. And tell me which way I'm moving.
Down, up, down, up.
Good. All right. So there's one other exam we can do for sensation, kind of, and that is with this little tool here. So Rachel, what I'm going to do is place this on your thumb and on your big toe, and I want you to tell me when you stop feeling the the vibration.
Now.
And we'll do the same.
Now.
And with your toes.
Now. Now.
Good. All right. So sensation appears to be intact. We can now move on to the reflexes. And so we're going to do reflexes of the upper and lower extremities. And so we'll start with the upper. So yeah, just rest your arm on your leg there. And we'll start with the tricep reflex. And then bicep. Good. The brachioradialis. Good. And same with the other arm. Good. All right, and now we'll move to the patellar reflex. So I'm going to try and elevate your leg, just kind of relax your leg. Good. Same with the other one, relax your leg. Good. And for the Achilles, what we do, I'm going to kind of relax your foot for me. Good. I'm actually going to kind of pull your foot back. Good. And with the other one. Good. So all reflexes and sensation appears to be intact. No neurological deficits were noted. For the final part of the exam, Rachel, what I'm going to have you do is stand up for me. And so we're going to finish out the range of motion exercises for the hip. So what I want you to do is, we did flexion, so I want you to do extension by sticking your leg out. Good, and do the same with the other. Good. And then for adduction, I want you to bring your hip across and do the same. And then abduction is pulling it out to the side. Good, so those are just hard to do while you're laying down. Some other exams we can do while you're standing. Actually, you would not do this for most patients while they're standing, but Rachel's coordination and sensation does appear to be intact. So what I want you to do, Rachel, is first we'll start with your upper extremities, testing for any ataxia. So go ahead and I want you to touch my finger and then touch your nose with one hand. And then, good, good, good. And then do your other hand. Good. One more. There we go. All right, and then you can also do the heel to shin, which most of your patients, in the hospital are going to be in bed, but most of your patients in the clinic are going to be back on the bench. So you're going to do heel to shin, up and down. Good. So that's just a testing for any ataxia, or another neuro kind of test there. We can also test just Rachel's gait. So we're going to do a toe walk on your toes. Good. And then a heel walk on your heels. Good. And then if you can, it's called kind of a tandem or a duck walk. Kind of walk like a duck for me. There you go. All right, good. So everything appears to be intact there. Other exam you can do is just a heel to toe walk, which is just heel to toe, kind of like you're walking a line there. Good. So balance is normal. Another test for balance or any neurological deficit would be the Romberg test. So Rachel, I just want you to close your eyes and just stand there. You just watch the patient and make sure they don't lose their balance, have any abnormal swaying or anything like that. So that is normal for Rachel. And the final part of the exam is going to be the spine range of motion exercises. So for that, Rachel, what I want you to do really quickly is just turn side, stabilize your hips, and just turn. There you go, with your spine side to side. And then lateral rotation, like you're picking up the suitcases. And then hyperextension. And then for flexion, if you can face that wall, I want you to bend over and try and touch your toes. And here is where you can assess the patient's spine for any abnormal curvatures. Could also palpate here again for pain, or any notice if there's any pain with that flexion. And there is not. So go ahead and stand up for me, Rachel. That concludes the comprehensive head to toe exam. Thank you, and thank you, Rachel.